In the emergency department, 2 people came in with rapid, shallow breathing and tachycardia. The first one is 45-year-old Olga, who also has systemic lupus erythematosus, and the second one is 39-year-old Fred. An arterial blood gas was taken, along with electrolytes. Results showed that Olga had low pH, low bicarbonate and PCO2 levels, and her potassium level was also low. Fred also had low pH, low bicarbonate and PCO2 levels, but his potassium level was high. Based on the ABG results, the diagnosis of normal anion gap metabolic acidosis was made. In order to identify the cause of their normal gap metabolic acidosis, more investigations were done and the urine anion gap showed that both individuals had a low urinary anion gap, which suggests that the cause was renal. Alright, now a normal anion gap metabolic acidosis can have renal causes, like when a lot of bicarbonate is lost through the urinary tract, which happens in type 2 renal tubular acidosis. A normal anion gap metabolic acidosis can also happen when too many hydrogen ions are retained, like in type 1 and type 4 renal tubular acidosis. Now there's also a type 3 renal tubular acidosis, where both the proximal and distal tubules are affected. This is a pretty rare situation, and the causes are not well understood, so it's unlikely to be tested. Alright, now let's review the physiology of the tubules. The proximal tubule is affected in RTA type 2. It's lined by brush border cells which have 2 surfaces. One is the apical surface, that faces the tubular lumen and is lined with microvilli, and the other is the basolateral surface, which faces the peritubular capillaries. Now, a lot of bicarbonate is reabsorbed here. When bicarbonate approaches the apical surface, it binds to hydrogen to form carbonic acid, which will be split into water and carbon dioxide by carbonic anhydrase. The water and carbon dioxide diffuse into the cells where carbonic anhydrase facilitates the reverse reaction and combines them to form carbonic acid, which dissociates into carbonate and hydrogen. Then carbonate will get into the blood with the help of a sodium bicarbonate cotransporter on the basolateral surface. Now, the proximal tubule is also responsible for reabsorbing glucose, as well as amino acids, sodium, chloride, potassium, phosphate, water, and uric acid. Alright, so now let's look at the distal tubule and collecting duct, which are affected in type 1 and type 4 RTA. First, they're lined with alpha intercalated cells, which also move bicarbonate and hydrogen from the tubule into the cell with the help of carbonic anhydrase. The alpha intercalated cells also secrete hydrogen across the apical surface and into the tubule, with the help of a hydrogen ATPase and a potassium hydrogen ATPase. Once in the lumen, hydrogen binds to phosphate or ammonia to form relatively weak acids, like dihydrogen phosphate or ammonium, which then get peed out in the urine. This allows protons to get removed without making the urine too acidic and damaging the cells lining the tubules and the rest of the urinary tract. The other group of cells in these regions are the principal cells. These cells have a potassium channel that allows potassium into the lumen, and an epithelial sodium channel that allows sodium into the cell. The flow of positively charged sodium ions into the cell helps drive the positively charged potassium ions out of the cell against their concentration gradient. There's also a sodium-potassium ATPase pump on the basolateral surface that again moves 2 potassium ions in for every 3 sodium ions out. All 3 of these channels are stimulated by aldosterone, and the combined effect is reabsorption of sodium and loss of potassium. In type 1 RTA, or distal renal tubular acidosis, the main issue is that alpha intercalated cells of the distal tubule and collecting duct are unable to secrete hydrogen. This leads to a buildup of hydrogen in the blood, resulting in acidemia, which will eventually lead to metabolic acidosis. With type 1 RTA, there's also increased potassium excretion to maintain electron neutrality in the renal tubules, so there'll also be hypokalemia. The underlying cause of type 1 RTA could be a genetic mutation in the hydrogen ATPase pump or the hydrogen-potassium ATPase pump of alpha intercalated cells. Alternatively, it could be due to an acquired defect from a medication like amphotericin B, which can allow hydrogen to simply diffuse from the tubule right back into the cell. Other causes include analgesic nephropathy, congenital anomalies of the urinary tract, and autoimmune disease like systemic lupus erythematosus, all of which can damage the distal and collecting tubules and decrease hydrogen secretion. On lab tests, type 1 RTA leads to a normal gap metabolic acidosis, meaning that blood pH will be low and levels of serum bicarbonate, potassium, and PCO2 will be low. But the anion gap will be normal. The urine pH is above 5.5, which is higher compared to other types of renal tubular acidosis, since hydrogen ions aren't excreted. Furthermore, metabolic acidosis increases urine calcium excretion without increasing calcium absorption. In order to get more calcium, bone turnover increases. This increases the risk for developing calcium phosphate kidney stones, which is a type of stone that forms in more alkaline urine. In type 2 RTA, or proximal renal tubular acidosis, the main issue is that brush border cells of the proximal tubule are unable to reabsorb bicarbonate. As a result, bicarbonate gets lost in the urine, and it means that there's nothing to counterbalance the hydrogen ions in the blood, resulting in acidemia and eventually metabolic acidosis. Now, since bicarbonate isn't reabsorbed in the proximal tubule, there will be a lot of bicarbonate in the urine as a result, and the high concentration of bicarbonate in the lumen leads to osmotic diuresis. This in turn causes mild hypovolemia, which activates the renin-angiotensin-aldosterone system, leading to sodium reabsorption and potassium excretion. So levels of potassium will fall, leading to hypokalemia. One known cause for type 2 RTA is Fanconi syndrome, where there's generalized proximal tubule dysfunction, meaning that the entire proximal tubule is damaged and won't be able to reabsorb things like bicarbonate, sodium, glucose, phosphate, uric acid, etc., and they're lost in the urine. On lab tests, type 2 RTA causes normal gap metabolic acidosis. pH is low and levels of serum bicarbonate and PCO2 are also low, but the anion gap will be normal. Potassium levels will also be low since they cannot be reabsorbed. Unlike RTA type 1, the distal intercalated cells are still functional, and can secrete hydrogen ions, and can therefore generally still acidify the urine, so the urine pH will be below 5.5. Finally, there's type 4 RTA, or hyperkalemic acidosis, and it's classically due to aldosterone deficiency or aldosterone resistance in the collecting ducts, which would affect both the principal and alpha intercalated cells. An example of aldosterone deficiency is Addison's disease, where the adrenal gland doesn't produce enough of it. Other causes include certain medications, like ACE inhibitors and ARBs, both of which can inhibit the release of aldosterone by blocking the renin-angiotensin-aldosterone system. Other causes include diabetic nephropathy and the use of NSAIDs, both of which can inhibit renin release. Aldosterone resistance can happen with the use of potassium-sparing diuretics, because they can antagonize the aldosterone receptors. Sulfamethoxazole trimethoprim can also cause aldosterone resistance, but the mechanism isn't clear. Whatever the cause, the aldosterone resistance can decrease the function of the sodium-potassium ATPase in principal cells, making sodium levels fall and potassium levels rise in the blood, causing hyperkalemia. Reduced effect on the hydrogen ATPase in the alpha intercalated cells decreases hydrogen excretion, causing acidemia. Also, since hydrogen usually combines with ammonia in the tubule to form ammonium, with less hydrogen there will be less ammonium excreted in the urine. So type 4 RTA leads to normal gap metabolic acidosis, where pH is low and there's also low levels of serum bicarbonate and low PCO2. Due to aldosterone resistance, there's decreased potassium excretion, leading to hyperkalemia. The urine pH in this case is usually below 5.5, but it can be normal if enough aldosterone is produced. Alright, as a quick recap. RTA is a cause of normal gap metabolic acidosis. It can develop in either the proximal tubule or the distal tubule in the nearby collecting duct. With type 1 RTA, the alpha intercalated cells of the distal tubule and collecting ducts are unable to secrete hydrogen, leading to metabolic acidosis. Hypokalemia and the urine pH will be above 5.5. With type 2 RTA, the brush border cells of the proximal tubule are unable to reabsorb bicarbonate, leading to metabolic acidosis and hypokalemia. But this time the urine pH is below 5.5. Then there's type 4 RTA, which is due to aldosterone deficiency or aldosterone resistance in the collecting ducts. This leads to metabolic acidosis, hyperkalemia, decreased ammonium excretion, and the urine pH is below 5.5, but it can vary. Alright, coming back to our cases. Both Olga and Fred came in with a normal gap metabolic acidosis. The urine anion gap was calculated, and this showed that the normal gap acidosis was of renal cause. Further investigations showed that Olga's urine pH was above 5.5 and she had hypokalemia, both of which suggest type 1 RTA, which is probably caused by her lupus. Bicarbonate is given to correct the acidosis. Now Fred has a normal gap acidosis with hyperkalemia, which suggests type 4 RTA, but more investigations are needed to determine and correct the cause.